So good morning. I mean, I can already see that you have had a long morning. What we're going to do today is we're going to present endocrine disorders in pregnancy. It's a vast topic in itself, as you can see that we will be trying to cover thyroid, pituitary, adrenal, diabetes insipidus, pheochromocytoma, and bit of a cons as well. Parathyroid, we are not going to touch much on it, but these are very brief presentations. We wouldn't expect you to know everything. And as I said, that it is a vast topic in itself. But let's touch base on what is most important. Well, my suggestion is I think thyroid is the most important one. Not because that's what I'm going to choose to present, but because majority of women we see in our antenatal clinic are either hypo or hyperthyroid. So I will be kind of going through both of it. Then later on, Zoe Slack, who is she was our F2, she just left us. She's quite kindly agreed to do two very interesting pituitary cases, and you would know when she presents it. In the end, one of our registrars, Manmeeta, she's going to present on other endocrine disorders, including Addison's and pheochromocytoma and whatnot. So just we'll try and keep you, as keep you as awake as possible. Let's hope you learn through, because it's quite important topic, especially as I said that we see quite a few patients. In fact, when we did an audit, almost 30% of our patients from maternal medicine side were thyroid patients. So it's a lot of chunk that we see in antenatal clinic. So touching base on physiology, thyroid binding globulin synthesis is increased, and that increases total T4 and T3 as well. So the TSH levels increase in pregnancy, and upper limit is 5.5 and not 4. So I really want to reinforce this fact, because what is happening is sometimes either GPs don't know that women are pregnant, or GPs are not aware. And when women go very early in the pregnancy to GP saying, I'm feeling very tired, which could be just a sign of pregnancy, they tend to do their TFTs, and then they diagnose them with hypothyroidism early on in the pregnancy. So our TSH levels are for the pregnancy, the upper limit is 5.5. So then they misdiagnose, and then the whole drama starts for us and the patient. Do we treat? Do we not treat? Patients, as you understand, are very worried about starting any new medication in pregnancy. And if we don't start, then the question is that, is it going to affect my baby? So we are in a catch-22 situation in the antenatal clinic. What do we do? So it's just, I would say, no unnecessary test, please, because that just causes a lot of hassle to everybody. So normal ranges of free T4 and T3 are reduced because obviously TSH is higher. TSH in its isolation should not be used to diagnose anything. So it has to be a full TFT taken into consideration. We all know that HCG has a thyrotrophic or TSH-like activity, and I will explain to you a bit more when we look at hyperthyroidism. So there is a relative iodine deficiency because there is increased maternal iodine requirement and there is increased iodine excretion. So hypothyroidism, only 1% of pregnancies have genuine hypothyroidism, but we do see a lot of women. I mean, we do definitely see more women than 1% of pregnancies, and I will explain to you what happens. The most discriminatory features, as you know, for hypothyroidism are cold intolerance, low pulse rate, and delayed relaxation of reflexes. Also, there is a lot of mood swings and depression, again, very common when you're pregnant. So the commonest causes which are encountered in pregnancies is Hashimoto's thyroiditis, where the antibodies are positive, or women who have had the treatment for Graves' disease. So they do, up to 18 months, they do try them on antithyroid drugs. And if women don't respond, then they are offered an option of thyroidectomy. And these women post-thyroidectomy then need thyroxine as a replacement. So other causes are iatrogenic following radioiodine, thyroidectomy, drug-induced like amiodarone, lithium, and antithyroid drugs. So these are the trimester-specific ranges of thyroid TSH. I would suggest that we tend to keep TSH under 2.5 just as kind of to make it easy, because in Royal Berkshire we don't have trimester-specific ranges, but some units do have a privilege to have trimester-specific ranges, and they can adjust their dosages for women based on this. But it really depends upon what your unit can offer, where you work. So why it is important in terms of managing the thyroid. So I always ask that patients are seen very early on in the pregnancy, because with other problems, even if you see later on, it's not a huge issue. But with the thyroid, I mean, we are very particular, because we can make a difference in first few weeks of pregnancy. As you see, that fetal thyroid begins to make TSH at about 10 to 12 weeks gestation. So first few weeks, babies do not produce their own thyroxine, and that's why it's important that they get enough from their mom. And then appreciable thyroid hormone is reached by about 18 to 20 weeks, which is quite later on in the pregnancy. So it's very, very important that first few weeks of pregnancy are very important for thyroid patients. Fetus is heavily reliant on maternal hormone, especially in the first trimester. And the maternal TSH does not cross the placenta, but the thyroxine and thyroid receptor antibodies can. And these can be a problem for thyrotoxicosis, which I will mention to you later on. So what does hypothyroidism, effect of pregnancy on hypothyroidism? So majority of women have absolutely no problem as long as they are replaced adequately. They sell through pregnancy without problem. 1/4 of women, which is really not much, would require dose alteration throughout pregnancy. And there are various reasons, and I'll discuss 1 or 2 cases with you, and then you will realize what I'm saying. And there is a poor compliance pre-pregnancy, again, that's going to affect the whole scenario as well. So what does hypothyroidism do to pregnancy? These women can find it difficult to conceive, and as it can cause an ovulation. And here the problem comes, because half of our population who's being seen in fertility clinic, more or less as a cocktail regime, they use thyroxine. So even if their thyroid function test is within range, sometimes they aim to keep TSH under 2.5, which is again not necessarily a normal range when you're not pregnant. And that means these women are started on thyroxine. It's almost like a herbal tablet of thyroxine, 25 microgram they are started on. The problem is, then they get pregnant, and then they are referred to us to decide what to do. These women are already anxious because they have been through fertility issues. They have now conceived. They are very, very keen. They don't want anything happening to their baby. How do we counsel them? And most of the times we advise them and tell them that there is no added advantage, but because they've already started on it, they prefer to continue. And that's where the problem starts, because then half of the population comes to us in antenatal endocrine clinic to be seen because they are on thyroxine. They don't necessarily have a genuine hypothyroidism. So what happens effect on the pregnancy? They can miscarry quite early on in pregnancy, and hence quite a few women start contacting us the moment they are pregnant, because they think it's their thyroid which needs to be sorted, which is rightly the thing. Preeclampsia, not very common. Abruption or preterm delivery, low birth weight. Again, if the thyroid function test is not within range, that can happen. Stillbirth and PPH. These are rare complications. Miscarriage is probably commoner compared to other complications. Then what happens to fetus? I think the problem is, when we see babies, when they are born, they are absolutely fine. I mean, sometimes other than low birth weight, there is not a major complication. The problem starts at the age of 2 and later on, because then they have neurodevelopmental delay, deafness, stunted growth, and hypothyroidism. And because we don't necessarily see these babies later on, we don't know what has happened with them. So sometimes we just get a kind of a false sense of security that these women are selling well through pregnancy. So I'll just give you an example. There was a lady, she was referred to my antenatal clinic saying she's known to have hypothyroidism and was on good 100 microgram of thyroxine. But since she's become pregnant, she's refusing to take thyroxine. And I had a chat with her, and she said, oh no, I'm not really happy. I don't want to take anything which can affect my baby. And in fact, trying to reassure her that it's very important, that thyroxine is important for your baby, because baby is not producing enough. Then when I took her obstetric history, she mentioned to me that she has had a previous pregnancy and previous delivery. Everything was straightforward. Baby was 2.8 kilogram, but I mean, nothing, not as such a SGA baby. And she was very reassured. And I just asked her, how old is your child? She said, he's 3 and how is he doing? And then she started saying, yes, I mean, there is a bit of a developmental delay, and there you go. And then I told her that it is very, very important because she didn't take thyroxine even in her first pregnancy. We don't know whether this is the cause that the baby is affected, her child is affected. And at that point, we could kind of reassure her. And then she started on thyroxine. But that's very important because we don't see when they become toddler and children, we don't know what happens to these babies. So how do we manage? Pre-pregnancy counseling, as usual, is very, very important. We don't do them. We don't see these patients. So GPs are their first port of call. So they should be on adequate thyroxine pre-pregnancy. Sometimes they are under endocrine team and they tend to counsel them. At confirmation of pregnancies, we advise GPs to check their thyroid function test, but even before the results are available, we should increase the dose of thyroxine by 30%. And this is a nice guidance. So the 30% comes up to 25 micrograms. So if a lady is on, say, 50 microgram thyroxine pre-pregnancy, she would need around 75 microgram, and then check the TFTs and manage accordingly. So aim in pregnancy is to keep TSH under 2.5. So if you have to take anything, take home message, please remember this number, because you will be seeing these patients quite frequently. They come to DAU, you see them on labor ward, you see them at lots of places other than antenatal clinics. So this number is important. We need to keep it below 2.5. We should repeat thyroid function test every 6 to 8 weekly basis in pregnancy. Again, this is nice guidance. Some units, I think Oxford does it every trimester, and that's quite acceptable as well. It depends upon which guidelines you follow, but basically they need at least a minimum every trimester one thyroid function test to ensure that their TSH is under 2.5. And again, as I mentioned, because we don't have pregnancy specific, trimester specific ranges, that's why we follow TSH of 2.5. But 2.5 to 3 is unacceptable. So if they are in second and third trimester, 3 is acceptable. But again, just to keep it easy and simple, remember the number 2.5. So suppose a woman has a high TSH and you increase the dose. We are expected to check the thyroid function test in 4 to 6 weeks time. And this is to ensure that they are on a correct dose and they don't need any further increase in their dose. Okay. And after that, they can have a routine 6 to 8 weekly basis check on thyroid function test. We advise GPs to recheck this TFT 6 weeks postpartum, and most women will go back to their pre-pregnancy dose, because in pregnancy there is an increased requirement which stops after they deliver. So this is in short about hypothyroidism, and now we will start the hyperthyroidism. I think this is more complicated than hypothyroidism. I mean, with the hypothyroidism, we expect GPs to manage them. We expect that the thyroid function tests are monitored by their GPs. But unfortunately, it's not happening as we would like it to happen. But there is not much we can do. So with the hyperthyroidism, these patients are seen in joint antenatal endocrine clinic. These are complicated patients. We cannot expect GPs to monitor and look after them. So thyrotoxicosis can complicate 1 in 500 pregnancies. We don't see it often. I must say I haven't seen it myself. And the discriminatory features are weight loss, tremors, persistent tachycardia, and lead lag. Again, with the tachycardia, tremors, these are very common in pregnancy, but of course weight loss is not, and that helps to differentiate. 95% of cases are due to Graves' disease, which is an autoimmune disorder which is caused by TSH receptor antibodies. So these patients are, as I mentioned, they're seen because of Graves' disease during the pregnancy. So rarely we do see women who have had multinodular goiter, toxic adenoma, subacute thyroiditis, iodine, and again drug-related problems which would cause a hyperthyroidism. So what are the effects of pregnancy on thyrotoxicosis? So it often improves in pregnancy, especially second and third trimester. In fact, quite a few percentage of women actually come off their anti-thyroid medication in second and third trimester. We monitor them very closely. They have their blood test every 6 to 8 weekly basis, and few of them are actually off medication. The reason is levels of TSH receptor antibodies may fall due to pregnancy, and hence there is a lower dose which is required for antithyroid medication. The exacerbation can occur, so the first trimester and the puerperium, these are the two timings where we really have to closely monitor women. So in first trimester, it is because obviously HCG, excessive HCG production, it has a TSH like activity, so it can be a problem. And in early puerperium, it is because there is a reversal of fall in antibodies. So these are the two timings where we really need to be careful about these women, and we warn them about it. So what can thyrotoxicosis cause? So compared to hypothyroidism, this can cause more problems. So severe cases, the anovulation and infertility is quite common. So low birth weight, high preeclampsia, heart problems, especially tachycardias, premature birth, thyroid storm again, which involves a severe worsening of the patient, is not that common. So other thing which needs to mention is retrosternal extension of goiter, which can cause tracheal obstruction. So when I had read, I thought it was quite uncommon for women to have these kind of symptoms. But I must say, in last 2 years, I have had two patients. Both of them had goiter, which increased in pregnancy. Then we referred them to ENT. They had thyroid scans. They had further bronchoscopies. And with the first patient, there was no retrosternal extension. And she said through the pregnancy and post-delivery, she managed to have a surgery. But with the second one, her goiter started causing her problems. She couldn't sleep like flat. I mean, not that we expect them to, but she started having like a stridor. She was waking up in the middle of the night because of the goiter getting bigger and causing a compression. She was getting shortness of breath. So this patient, then we had to deliver her not too early. Thankfully, by the time this all got investigated, she was around 37 weeks. So we induced her and delivered her, because again, as you can imagine, the anesthetists were worried as well, because we were considering a difficult intubation in view of this goiter. And I remember this lady very well, because this was a lady who was already 41, was known to have goiter, had a previous actually she had a previous home birth, which was very straightforward, except the fact that baby ended up being admitted later on. So personally, because of her age and a large goiter, I was not very keen for her to, because she's not considered low risk anyway, and previous baby needed admission immediately after delivery. So these were not the best of the things for home birth, but she was very keen, adamant that she will have home birth. Again, this pregnancy, then this goiter got bigger. Then she again was insisting that if I don't need a surgery right now, can I still labor at home? Then I explained to them, the labor was never a problem for her, but if she needed any immediate intervention and needed transfer to hospital, she was considered a very difficult candidate for intubation. Unfortunately, she did not listen, but we were kind of lucky that she ended up having a normal delivery, and then they will be considering surgery for her in future. So yes, the goiters can be a nuisance. So gestational hyperthyroidism, again, this is important. You may see this especially when you see patients in early pregnancy units, because HCG mimics TSH and stimulates thyroid hormone production. It's very commonly seen with hyperemesis gravidarum, because when we do thyroid function test as a part of screening, you may find that it gives a hyperthyroid picture. I would suggest that we don't start them on treatment straight away anyway, but it's good to get an opinion from endocrine team. We advise to do antibody test at the same time. And then we advised to do repeat thyroid function test in a couple of weeks. As the hyperemesis improves, the thyroid function test improves automatically, especially by second trimester. They are euthyroid. But the problem is, I have seen one or two cases while I've been at Royal Berkshire, that hastily these patients were started on treatment. And again, and right thing was done. We had asked the endocrine team in these situations, but bear in mind, not not all endocrine registrars are very familiar with the pregnancy physiology and pathology either. So they had started them on treatment. We eventually took them off. But it is very important, and we have to differentiate again from Graves' disease. That's by doing the antibodies. Very occasionally, they do need a treatment. Not all can escape without it. So how do you manage thyrotoxicosis? So basically, antithyroid drugs is the treatment, and aim of the treatment is to control thyrotoxicosis as rapidly as possible and optimally with the lowest dose of medication. Women should be euthyroid clinically and with the free T4 at the upper end of the normal pregnancy range. Achieving this is not always very easy, but we try our best. So what medication is safe? Because these women are going to be quite worried, PTU or carbimazole. So the new guidance suggests that if they are on PTU and their disease is well controlled, there is no harm on continuing them on PTU, which is a propylthiouracil. The only slight problem is with the liver impairment, and we can monitor their liver function test. But ideally, PTU is good for first trimester, and then if women are happy, we change them to carbimazole in second and third trimester, and which is okay postpartum as well, especially if they decide to breastfeed, because a very small amount only goes into breast milk. So if some women then decide to be on carbimazole from the start, we tend to let them continue on that, because at the end of the day, if their disease is very well controlled on it, then we don't need to worry. So carbimazole and methimazole, there is a condition called as aplasia cutis, where the skin literally peels off from baby, and that's quite scary when you tell them, and that's why women may not necessarily want to be. Again, very rare condition, and it happens only when they are on a very high doses. We did have a lady who was on carbimazole over 150. Sorry, not carbimazole, PTU over 150, or carbimazole of more than 15 milligram when she was shifted onto carbimazole. So these kind of dosages are something where we would worry. But normally with a small dosage, it's unlikely to cause a huge problem to babies as well as mom. As I mentioned to you earlier, Graves' disease can flare up postpartum. So we don't see them postpartum. They do go and see their GP. So our job is to actually just counsel them, make them aware that they can have a flare up, especially women who are not on medication during pregnancy or come off during pregnancy may need to go back to their antithyroid medication postpartum. So it's again quite important. Continuing the management, beta blockers, short periods can be used if they are very symptomatic of tachycardia. That can be given. Surgery, thyroidectomy is very, very rarely indicated, but if at all it is required, it is best done in second trimester. So as I mentioned, the two cases where there was a retrosternal extension, and if it had caused a compression and patient had a problem, then we would have probably operated them in second trimester. But in third trimester, it's easy to wait, take a chance, and they maybe deliver them slightly preterm, and then do a surgery later on, because it's very difficult even to ventilate in the third trimester. So to do a surgery on thyroid would be quite tricky. Radioactive iodine definitely contraindicated. And those women who have it as a treatment for Graves' disease, we advise them to avoid pregnancy at least 4 months after the treatment. Those women who have a good control on antithyroid disease drugs, or the disease has been in remission, the maternal and fetal outcome is very good. It's not affected by thyrotoxicosis. As I said, the PTU very little is excreted in milk, and if they are on dosage of PTU which is more than 150 or carbimazole over 15 milligram, then we need to monitor them very closely. So slightly touch base on fetal thyrotoxicosis. It occurs in only 1% of babies. It is extremely unlikely to happen if these women are under endocrine clinic. They have been managed, they have been monitored. Of course, if we don't have a compliance, there is not much we can do. But basically, this is due to thyroid receptor antibodies, which can cross the placenta and can cause goiter and hypothyroidism, and can cause thyrotoxicosis to the baby. So the way we come to know is that if fetus is tachycardic, there can be IUGR to the baby. So these babies then have a serial ultrasound, and sometimes we need to give women medication and treat them which would, like, especially with the thyroxine, which would cross the placenta and treat the thyrotoxicosis. We also ask sonographers to look for any goiters on ultrasound scan. So so check the neck of the baby, which is quite tricky, but if there is any goiter, they can find on scan. So that's what we would ask sonographers to do. Then some women actually develop thyroid issues after pregnancy. And why does it happen? So postpartum thyroiditis, again, these are women who are not under our radar anymore because they are monitored by their GP. They are looking after their baby. Some of them already have got 2 children. So they are very busy. The symptoms they develop, sometimes it could be hyperthyroidism or hypothyroidism. Part of it can be thought as a depression related to having a child, trying to do too many things, and can get very easily neglected. So it's an autoimmune condition which is associated with TP antibodies. 5 to 10% of women are affected with it. It can occur 1 to 6 months postpartum anytime. And as I mentioned, some women have symptoms of hyperthyroidism, some have symptoms of hypothyroidism. Again, because women are so busy, they really neglect these symptoms, do not see their GPs necessarily. Some of them just needs monitoring and eventually get better, and small percentage of women do need anti-thyroid medication if they start with hyperthyroidism. So in short, this is our referral pathway. And I just wanted to tell you, I mean, I know you are from different hospitals, but this is something which can be adopted in other units as well. What we did was, as you understand, at the moment, GPs are very reluctant to manage thyroid patients. They do not have a capacity. I mean, those who have sat down in clinic with me, 6 out of 8 women literally cry on the phone saying their GPs are not doing any thyroid function tests. Do they need to come to the joint antenatal endocrine clinic, which is run by, say, an obstetrician and endocrine consultant? No, they don't really need to come there, because what would we do? These are women who are very straightforward, and in some areas they are managed by GPs only, and they don't even need to be referred. But when we had a discussion with our GP commissioners, they were not happy to take over care for even low risk patients. So what we have done is we have devised this clinic where we have an endocrine physician associate. She runs the clinic for low risk patients, which is very good, and one of its quite innovative clinic in the country. Not I haven't come across many clinics. I mean, endocrine PAs do clinics, but this is something which we started in Royal Berkshire. She sees all low risk patients, monitors them, manages them, and then all complicated patients then come to antenatal endocrine clinic. In all fairness, do we need this? Because ideally GP should be managing this, but because GPs are not did not have a capacity to monitor. Also, when I had a discussion with them, again, it's important if you have your friends who are GP, and I tend to ask GP trainees also to come and attend the antenatal endocrine clinic. Only reason is because GPs are saying that they don't see pregnant patients that often, because most of the patients come to us. So they tend to lose their expertise in these matters, and hence the whole situation can become very complicated. They don't understand how to manage this, and a slight dose adjustment, they straight away refuse to do it, and that's because of the lack of the knowledge. At the moment, they are concentrating again on vaccination, so they have found it another way of coming out of trying to look after these patients. So this is how we have adopted to the change, and is working quite well at the moment. This is a first case I just wanted to discuss. So 18 weeks pregnant patient. She was seen in joint antenatal endocrine clinic due to hypothyroidism, and her TSH was 3.5 at booking at bloods. And GP increased her thyroxine to 75 microgram. And I think that's a right thing to do. Then she had repeat bloods at 6 weeks later, and her TSH was 2.7. Another GP decreased the thyroxine from 75 microgram to 50 microgram. Do you think it's the right thing to have done? I mean, you can unmute and let me know. Are you still there?
I think you said the target was 25. Oh, sorry, it was 2.5, right? So it should have possibly even gone slightly further up.
Yeah, that's correct. And that's what, as I said, that even if these patients were under GP, the results were reviewed by GP rather than doing increasing it to 100 microgram. GP decreased it to 50 microgram. Okay, so that's not the right thing to do. And that's why I just thought it's very, very important that at least you guys know, especially if you get a phone call from GP because they don't know, or if you see them in as a day assessment unit or in antenatal clinic, because it doesn't necessarily have to be a joint antenatal endocrine clinic. Sometimes these patients do come into other clinics as well. So the GP probably didn't know what was the target range for pregnancy, and that's why he decreased rather than increasing. And this is not unusual. We see it quite often, and that's why there is always a worry about these patients being monitored in the community. So the next case, this was primip, 30 weeks, low risk pregnancy except hypothyroidism. She was seen in clinic for follow-up. Her last ESH was documented as 3.5, and these were the times when we had, those green notes where we were documenting when we were looking at patients rather than everything being on EPR. So this was a pre-EPR era. Patient saw her GP with these results, and GP documented in pregnancy handheld notes that the results are normal and she should continue with the current dose of thyroxine. So, what do you think? Is this the right thing to have done? I mean, I of course you would agree that this shouldn't have been done, but because it wasn't, there was not much I could do. If I told patient, then she when I told patient that her dose should have been increased, she was furious. She said, I did the right thing. I did my thyroid function test as you advised me. I went to GP to show them. And because I almost had an evidence that GP had written in her handheld notes as well, to say that this was a right dose, because GP forgot that 3.5 is not a correct range for pregnancy. So even though she had a kind of a contact with a doctor, it didn't help her. So this is how things are, and that's why we need to be very careful about how we manage these patients. So from my point of view, this is mainly on thyroid. As I said, I've covered hypo and hyperthyroid. There is a bit more to cover, which and from other endocrine problems. Before I hand over to Zoe, I just wanted to tell you, in terms of thyroxine, please make sure that patients are taking it empty stomach. It should be at least 30 to 40 minutes before their breakfast, because a lot of women will tell me, oh no, I take it as a first thing in the morning. But when you ask them more, then they immediately have a breakfast. So it doesn't help. So please do ask them to take it when they are fasting and not eat. And can anybody tell me why we ask women to take it empty stomach? Does anybody know? So it's basically because the gastric acid helps to absorb the thyroxine. So it's very, very important that these women take it empty stomach. So secondly, then I recently, literally last week, saw a patient. We had increased her dosage to 75 microgram. She had repeat thyroid function test, and it still hadn't improved. So we were just thinking, what is the matter? Why her thyroid function test has not improved in spite of increasing her thyroxine? So I asked her in more detail, and she said, no, I'm taking it empty stomach. I'm leaving 30 to 40 minutes before I have my breakfast. So I said, that's great. I mean, you have taken it in the right way. That just means that you need a higher dose. And then I asked her, are you taking any other medication? And then she says, oh yes, I'm taking iron tablets with it. So again, it's not something I advise, because iron would not help to absorb the thyroxine in the right amount. So we always tell patients that thyroxine is not a friend of anyone. So do not take thyroxine with any other medication. Okay, so that's important thing. Then third patient, literally again seen last week, increased her dosage to 100. No, haven't seen major response. I asked her, yes, I'm taking it empty stomach, having a breakfast later on, keeping 30-40 minutes between. And I don't know what I'm doing. I'm really worried. Patient was really worried. And then I asked her, have you been well? Has anything changed? No. But then she's mentioned to me that I was developing a lot of reflux. So I've started, my GP has prescribed me omeprazole, but GP did not tell her because she was getting more reflux in the morning. After waking up, she started taking omeprazole with levothyroxine. So as you understand, that's not going to help because omeprazole would not help absorption of thyroxine. So that's why it didn't help her. So clearly there are very little things which, especially with the hormones, we have to be very careful. Careful history taking is important. What patients are doing, how patients are taking thyroxine. So if you see them, please do take a detailed history from them about how do they take their thyroxine. This is important. Yeah. So do you want to just copy this QR code so that you can do us a feedback later on? And then I will ask Zoe. Zoe, if you keep your presentation ready so that you can upload it. So if you have copied this QR code, has everybody got that?
Yes, thanks.
Thanks. Okay, I'll stop presenting. So that's it from me. Zoe, if you want to upload your presentation then, yeah, and start.
Yeah.
So Zoe has kindly agreed to do presentation on pituitary tumors. So we have had very unusual 2 cases literally in last year. Doing this job for a while, I didn't think that pituitaries can cause a major problem in pregnancy. And sometimes I used to almost wonder, why are we seeing them so often as well? But to my surprise, we had these 2 cases, very interesting. And I will let Zoe present it now. If you have, before we start, do you have any questions on thyroid, or we can just do it later on as well, wherever you want? Okay, I'll let Zoe present then.
Oh, bear with me 1 second. Let me just get the updated one. Can you see my screen?
Zoe, we can. I thought you had opened the right one. I don't know.
Yeah, I thought I had 2. Sorry.
Don't worry.
I thought I was ready. There we go.
Yeah, there you go.
Perfect. Thank you. So I'm just going to present a couple of cases on pituitary adenoma. I think they're both really interesting. So the first case is a 23-year-old primate. She had a known past medical history of a non-functioning pituitary macroadenoma with mild hyperprolactinemia. She was also GBS positive, but none other past medical history. She was Hungarian and English was her second language, and I think that this did impact on this case a little bit during her journey through her pregnancy. She also smoked 5 cigarettes a day for the past 5 years, was currently furloughed and wasn't taking any medications at this time. So the year prior to her becoming pregnant, she was diagnosed with this prolactinoma. This was diagnosed because she had had 3 years of galactorrhea, about a year of headaches. She'd also been experiencing polyuria, dizziness, some nausea without any obvious causes, no recent stresses. And she also had no visual field defects. She was referred to endocrinology, had a serum prolactin measured, and that was around 1900, which is extremely high for a sort of non-pregnant lady. She had normal renal and thyroid function, and then she had an MRI pituitary organised in March 2020, and here are the images. So we can see quite clearly, hopefully, in this MRI that she has this a pituitary mass. It's displacing the infundibulum to the right. It's invading the left cavernous sinus. It's also causing upward displacement of the diaphragm celli, and the lateral extension of it just abuts the left internal carotid artery in the cavernous sinus. I hope that's clear on the images. I think due to sort of a bit of a language barrier, she didn't really appreciate the diagnosis. She then subsequently didn't attend a number of appointments with endocrinology. Eventually, in June 2020, 3 months after the diagnosis, she was started on cabergoline, 250 micrograms twice a week. This is a dopamine agonist which inhibits prolactin, serum prolactin, with the aim of reducing the serum prolactin level and then reducing the symptoms. She was advised by the endocrine team to stop cabergoline if she was to become pregnant, and then to immediately contact them to let them know. There was a plan to monitor the size of the pituitary every 3 months, and then to consider neurosurgery in the future if it was to become larger, or if it was to start to exert pressure effects on the brain. And then follow-up was arranged for 1 month later. So after being on treatment, her serum prolactin level reduced really nicely down to 833. Her menstrual cycle normalized, and the galactorrhea stopped. She had some side effects of GI symptoms, nausea and diarrhea, and this is quite a common side effect of cabergoline. And then in September 2020, 6 months after the diagnosis, she fell pregnant. So now we're going to look at her pregnancy journey. So 12-week scan was normal. In December 2020, she was seen in antenatal clinic. She was complaining of intermittent headache, but denied any visual disturbances. She just stopped the cabergoline as directed by Endocrine. And there was a plan made to have her visual fields checked every trimester and then to be seen in antenatal clinic again at 32 weeks. In January then, just 5 to 6 weeks later, she was seen in ophthalmology clinic urgently as she'd been complaining of a headache with blurred vision. They did a visual fields assessment and she had a bitemporal hemianopia with the right side worse than the left, and they organised an urgent MRI pituitary. So I think the following day, she had another MRI, and you can clearly see that the adenoma is greatly increased in size, and it's now compressing the optic chiasm, which is why the patient is experiencing the hemianopia. So there was an urgent referral to neurosurgery. They contacted the patient by telephone. She was complaining of blurry vision, headache, dizziness, but hadn't had any collapses or any nosebleeds. They asked to review her in person. She didn't attend due to the headache. And I think this is where the language barrier came into play, despite all of her sort of consultations being done with the help of a Hungarian translator. She obviously didn't realise the importance, the importance of the headache and how that was related to her diagnosis. So when they did manage to see her in the ambulatory clinic, she'd had a headache for about a month. It was frontal, it was acute onset, mostly in the mornings, 3 times a day. It was getting worse, but she didn't have any postural symptoms or collapse or fever, and her bloods were actually normal. So there was a plan for the MDT and to restart the cabergoline. I had a little look. Cabergoline apparently is safe in pregnancy, and it just suppresses the prolactin increase associated with pregnancy. Then on the 2nd of February, she had a transsphenoid resection of the pituitary macroadenoma, and this was in Oxford, so we don't have the notes on our system. But 5 days later, she presented to the emergency department with a headache, radiating to her right eye and her neck, and had been vomiting. They did some bloods, reviewed her, and an Addisonian crisis was excluded. And she was just admitted for monitoring, and her symptoms resolved. So after you have a transsphenoid resection of pituitary or any sort of trauma to a pituitary, you can get Addison's disease, and which is why she was started on the hydrocortisone regularly. And it can also cause diabetes insipidus, which is why she was started on the desmopressin after the surgery. So after she was discharged from ED, there was a plan to do a short synaptin test a few weeks later, and to keep monitoring the visual fields, and to do an MRI after delivery of the baby. So then she had a normal fetal ultrasound scan at 30 weeks. Her short-synaptin test, which tests for Addison's disease, was normal, so we stopped the hydrocortisone. She didn't have any further headaches or visual disturbances, but she was complaining of increasing urinary frequency and thirst on the background of having stopped the desmopressin of her own accord. I think she'd run out of tablets, and then because her headaches had improved, she thought that it was okay to stop taking. Serum urine osmolality was abnormal, and there was a plan to repeat that after a water deprivation test to confirm the diabetes insipidus before restarting the desmopressin. Again, it was quite difficult to get hold of her. She didn't attend. I think she didn't attend for the water deprivation test, and she was late to an antenatal clinic appointment. She was briefly seen in DAU, our ambulatory assessment unit, with PV bleeding. She was diagnosed with ectropion and candida and was treated for the candida. And then she failed to attend a visual fields review, which was rearranged. She had a joint endocrine antenatal clinic, which she was complaining of polyuria and the symptoms of diabetes had improved at that point. So I don't think she was ever restarted on the desmopressin. She had normal visual fields in April, and a few days later, she was complaining of clear fluid draining from both nostrils. However, she'd had her surgery at the beginning of February, and it was now end of April. So when she was seen in the endocrine clinic, they felt it was unlikely to be CSF draining from the nostrils, but they advised her to collect the specimens anyway. So histopathology of the pituitary showed a lactotroph, which lactotrophs are the cells that secrete prolactin in the pituitary. And that was the reason why she had high prolactin, serum prolactin levels. And that was to be discussed in the MDT in Oxford. She continued to have normal growth of her baby. And then in May, another joint endocrine antenatal clinic, all of her symptoms had resolved, and she was planning to breastfeed, and she was requesting an elective section. So on the 17th of May, she had a Cat1 elective section for fetal bradycardia. That was the day she had her elective section booked for, and then I think a fetal brady was diagnosed, and then they escalated it to a Cat1. Baby was born in really good condition, just had GBS observations, and wasn't admitted under the neonatal team. Normal amount of blood loss. And then a couple of months later, unfortunately, she failed to attend her endocrine follow-up. She missed her follow-up MRI, and she's now moved to Preston. So we have no further notes on her, which is quite dissatisfying, but quite an interesting pregnancy journey, I think. Does anyone have any questions about that case to start with?
Zoe, I just want to add, it was for everyone who is listening, this was extremely difficult for us to manage this lady because a language barrier, and she never took her health seriously. There were so many phone calls. Endocrine was on top of everything. They were ringing her. And we all were trying to contact her at times, and she just wasn't attending the clinic. We tried to send our community midwife to her house to make sure that she understands. But I think, as Zoe mentioned, the case was made more challenging because of the language barrier and the whole. She's vulnerable adult because she literally is not paying any attention to her health, and that's why she kept on missing appointments. And initially it was difficult even to understand whether she has a genuine problem or is it the language barrier, which is and she's complaining of normal pregnancy related symptoms. But in the end, at least from our point of view, she had an appropriate management. So continue, Zoe.
Yeah, I think it was managed really well overall. When I was going through the notes, there was just so many inputs that were just attempted to contact patient, no answer, no reply, no response, didn't attend. So it was really difficult. And I think every time that she was spoken to was with a translator. So I'm not sure what else more could have been done to help her. And ultimately she did have the right treatment and a good outcome in the end for her and her baby. So. So the second case is a lady who was diagnosed with a macroadenoma during pregnancy. So she's 32 years old, no past medical history, sister recently diagnosed with a brain tumour, which I think just added to the stress of this situation. Works as an optical engineer and was having regular periods at the time. So she had a normal 12-week scan and a normal anomaly scan. In February 21, she contacted maternity triage. She's complaining of headaches, frontal, not relieved by paracetamol, had no other associated symptoms of preeclampsia. She was reviewed, and it was felt sort of on remote review that this could be related to working from home, sitting at a computer all day, and they weren't worried about any of the features that she described. She'd seen her GP earlier that morning, so she wasn't seen by a doctor that afternoon. A month later, she attended the ambulatory unit for reduced fetal movements. As soon as the CTG went on, she did feel movements, but the CTG didn't meet criteria on 2 occasions. So she was discussed with the consultant. She had an ultrasound scan, which was completely normal, and there was a plan to repeat the CTG again the following day. About a week later, she had an antenatal clinic appointment, and she was just planned to have regular growth scans with a telephone conversation afterwards. She then had another CTG, which again didn't meet criteria, but the subsequent ultrasound scan was completely normal. And then at 31 weeks plus 6, she was complaining of headaches for a few days. She had blurred vision, swollen feet, itchy feet and legs. She had normal blood pressure and normal fetal movements. She attended DAU and was seen by one of the SHOs. So again, at that time she was presenting with headache, nausea, vomiting, diarrhea, edema. And she said she had 6 weeks loss of peripheral vision in both eyes, which began in the right eye and then progressed to the left-hand side, denied headache or vomiting. So she had some bloods done and she was hyponatremic on the formal bloods. And it was felt that the headache could be due to sort of dehydration and the hyponatremia, but the hyponatremia resolved when they repeated it on the VBG. And I'm told this is a difference between the solutions that are, so the solution in the formal blood bottles can give you a falsely low sodium, but a VBG can be more reliable. And at the time she also had a scan which was normal. She saw an optician and was referred for an ophthalmology review due to the visual disturbances. And again, the visual fields show bitemporal hemianopia, which was denser more superiorly. And again, they organised an urgent MRI pituitary. So the next day, she had the MRI pituitary. And this again shows the pituitary fossa is expanded by a uniform intermediate signal mass, which extends superiorly into the suprasellar region and laterally into the right parasellar region. The suprasellar component largely obscures the infundibulum and abuts and displaces the optic chiasm superiorly, hence the visual field defects. The optic chiasm is draped over the superior margin of the mass. Lateral borders of the mass abut the carotid arteries, with a small tongue of soft tissue extending superiorly over the cavernous segment of the right internal carotid artery. Presumed pituitary macroadenoma. And advised to have a contrast pituitary MRI and a neurosurgical opinion. She continued to have normal growth scans. And then she had an endocrine review on the 7th of May, which was a normal exam. And through discussion with obstetric team, there was a plan to expedite the delivery within the next couple of weeks. With a elective section, check the random cortisol and the thyroid function tests, give perioperative steroid cover and weekly visual fields, no immediate postnatal neurosurgical plan. On the 10th of May, she had an endocrine review and she was diagnosed with Addison's and secondary hypothyroidism. So she was prescribed hydrocortisone and levothyroxine, and it's important that we start the hydrocortisone first and then the thyroxine to avoid precipitating an Addisonian crisis. She had a short synaptin test planned for post-delivery. They also measured her serum prolactin level, which was 2,420 at this time, but she was also pregnant, so we would expect it to be elevated, and that has to be interpreted in the context of pregnancy. And she had no features of Cushing's disease at this time. The next day, her visual fields were reviewed, and she had a bitemporal hemianopia, and then an elective section booked for the 14th of May. She had an elective section without issue, minimal blood loss. She was given IV hydrocortisone until she was eating and drinking again, then switched to stress dosing of hydrocortisone, and then maintenance dosing of hydrocortisone. And then she was started on levothyroxine one day post-delivery. She was had an uncomplicated postnatal period, was transferred and discharged quite quickly after surgery. Following delivery of the baby, her visual fields completely normalised. So they held the plan for neurosurgery as all of her symptoms had improved. Her short synaptin test was normal, and child development was normal at this time. And then she had a repeat MRI in July 21, and this shows that the pituitary lesion has reduced in size. And no longer compresses the optic chiasm, and you can now see a thin layer of CSF on the scan. And these are the images with the contrast as well. So the plan postnatally is to have a surveillance MRI pituitary every 5 to 6 months. She's got one booked for January next year, and then to have an early MRI and visual fields in future pregnancies. And to reduce her steroids slowly. So just a little bit about pituitary tumours. So 10 millimetres is the cutoff as to whether it's a microprolactinoma or a macroprolactinoma. Microprolactinomas are quite common and can sort of cause minimal symptoms. Both of these things are benign. The symptoms are associated with the serum prolactin release, which can be amenorrhea, galactorrhea, and then also the pressure effects if the prolactinoma increases inside, which is the headaches, the nausea, the dizziness, and the visual field defects. Obviously, there's minimal benefit of measuring the serum prolactin if a patient is pregnant. And it's important to clinically monitor the symptoms of headache and peripheral vision if somebody is presenting with a headache. If somebody does have a prolactinoma, it's important that they have visual fields monitored in every trimester of their pregnancy. And cabergoline can be safely continued in pregnancy and in breastfeeding, but women may find it difficult to breastfeed whilst on cabergoline because it suppresses the serum prolactin. And that's the end of my presentation. Thank you for listening.
Thank you, Zoe. It was very interesting, as I'm sure everyone else will agree, because these are very rare cases. And as I said, pituitary tumors are not itself common in themselves. And then for them to cause a problem is very rare. Like with the first lady who was Hungarian, we were not even planning to see her other than doing a visual field test. And she needed a surgery during pregnancy, which is quite a complicated matter. And with the second one, as you mentioned, that again, headaches are so common in pregnancy. And if you see somebody with headache and blurring of vision, the first thing we would worry about is a preeclampsia rather than any endocrine problem. So clearly we were not even thinking remotely of pituitary adenoma at any stage in these pregnancies, as you all will agree. The only thing I would like to mention is when she was seen on 6th of April, headache, we all see so many patients, and she looks, looking through her pregnancy journey, it feels like she was a lady who was probably a bit worried and had been presenting few times. And so it's very difficult sometimes to actually come to a conclusion whether this could be a genuine problem, or is it an anxiety making her attend so many times. So when she attended on 6th of April and was seen in DAU, my only I think I would like to add is she mentioned about loss of peripheral vision. And again, this is not a very common thing we see. It's not something happens with preeclampsia or migraines or things like that. So when this could have been our point of call where I don't know whether we missed doing further investigation. At least she went to the optometric people, which was the right thing to have done, who diagnosed her with bitemporal hemianopia, and then the further investigation started. I must say, when I started doing clinics and when I looked at endocrine people asking for this visual function test, I thought it's such an ancient test, and does it really add to anything? But as you can see in both cases, it has given us a very valuable information, even if it's such an old and a test where it's not as fancy as MRI. So I almost always wondered why they did it, but clearly it has proved very useful, and we are still using visual function test as a screening test. And these women have it, as Zoe has mentioned, every trimester. That is arranged by the endocrine team, and they interpret it and make sure they are within range. So that's from the pituitary side. Thank you very much, Zoe.
Can I interrupt? I had a question about the visual field monitoring. Is that just a clinical assessment, or do the ophthalmologists have a more like a machine, a more objective way of assessing the fields?
No. There is an objective way, and I wish we had put it. So it looks like they, when you go to optometrist, so along similar to that, when they do visual fields, there is a graph of every quadrant. Right. And every quadrant graph, so there will be dots in every quadrant, and if you see areas missing where patient has pointed out that, or patient has not seen that area, then it's very obvious on the graph. So it's like a graph, like an XY axis, and they plot it on that graph, and they don't interpret them as such. Only when it's an abnormality, I mean, they can figure it out immediately. But our endocrine team actually physically reads that graph and then talks to the patient and talks to them about it.
Thank you.
Does somebody have a question again?
Yeah, hi, it's Despina, one of the ST1s. I have a question with regards to who is the most appropriate person to be doing those visual fields tests, both on first presentation and then on follow-up. Is it sufficient that, for example, an SHO that sees someone on maternity assessment center or DAU does them, or do we have to refer to neurology? And who is the most appropriate person to be doing them, and who should be doing them both on first presentation and on follow-up after?
No, I don't think you would be able to. I mean, I'm not sure whether you can even request, because for us it is requested by the endocrine team, because I think you have to give enough clinical presentation for them to be done. To be honest, I have been told it's post-COVID, some of the units are even struggling to get as many visual fields, like even we get at least 3 done in pregnancy. Some of them are even struggling to get them done because it's considered as such a routine service and they are not given a priority. I wouldn't advise that you do visual function test for everybody. I think our first port of call, even with the second patient, would have been at least to ask her to go take an opinion from ophthalmology team, whether it is normal for somebody to have a loss of peripheral vision. If that's not the case, I think we should just hand over to them, because we are not an expert. We can't interpret these. I wouldn't interpret them myself. They are interpreted by endocrine team, as I said. So they are an expert, and so medical team is and the ophthalmology team is an expert. You may not be even able to request them. I think the best thing in this situation is to kind of seek an opinion from either a medical team or an ophthalmology team, depending upon what you see, really. And again, not all headaches are going to be pituitary adenomas. I don't want to confuse, but I just felt like in this case, she was presenting very recurrently with headaches. She also mentioned about loss of peripheral vision, but and it's very common thing, because when I was a similar stage as yours, we see so many patients, everybody has a headache, everybody has some problem, and you just don't know who is a genuine patient. But I think we could have done something. We could have at least obtained an opinion from the ophthalmology team, and they would have advised us to do it. But no, I wouldn't expect you to do visual function or arrange a visual function on your own. I don't think you can do that.
Yes,
I guess as well, like the first patient already had a known prolactinoma, and then the second lady, she worked as an optical engineer, which is why I included it in the presentation. So I'm not sure if, because she complained, and then we reassured her, and then she had an optician's appointment. So I'm not sure if she kind of had access to a formal visual fields assessment and was concerned and spoke to colleagues. And I'm not sure if maybe her experience as an optical engineer potentially helped her knowledge or her concern, and if it was somebody else, maybe that wouldn't have been the case.
Okay, quite interesting how you can influence things, because yeah, I think yeah, it's really difficult. When we see them first in the clinic, these pituitary patients, they all have their visual function. In fact, endocrine team, the moment they get pregnant, they have been advised to inform the endocrine department, because they're already under endocrine department, and they start arranging visual function test for them. And obviously then we advise them to stop cabergoline. I just wanted to also mention one of our patients, she has a microprolactinoma, and to be honest, it should not cause any problem. I mean, majority of women would come off cabergoline in pregnancy, because they can easily manage. But this patient, the moment she stops cabergoline, we could say it is difficult to judge her, but the moment she stops cabergoline, she gets headaches, even if her tumor is less than less than 10 millimeter. So she's continuing cabergoline in pregnancy. We tried to stop it, but her headaches came back with vengeance, so she had to go back again on cabergoline. So it is a difficult one, but just bear in mind, cabergoline can be continued in pregnancy and postpartum, but they may not be able to breastfeed. I mean, we'll have to see. This lady hasn't delivered yet and has a wish to breastfeed her baby. We have said that it may not be possible, and sometimes women find it very difficult not to be able to breastfeed. So we have to give. We have given her realistic figures that it may not be possible to do it. But yes, cabergoline can be continued, and the visual function tests are done by not me. It's by the endocrine team. Obstetric team doesn't monitor them or interpret them. I wouldn't be able to. Okay. So thank you very much. If there are no further questions, I will ask Meeta to do her presentation. Meeta, you ready?
Yes, I am. I will just be sharing my screen. Can everyone see my screen?
Yes,
we can.
All right. So we've just touched base with the low risk and the most common endocrinopathies in pregnancy. And I'm just going to cover a bit about the moderate and the high risk disorders in pregnancy. So just for an overview, all women with endocrine diseases should have access to preconception specialist counseling, especially in conditions like congenital adrenal hyperplasia, where there's a risk of fetal virilization. The referral for counseling, and there should be a good plan in place for them to be referred for counseling and management plan. And usually in the cases of CAH, the management has to be commenced in the preconception period. Also, the antenatal care in all such endocrine patients, it should be in liaison with the patient's endocrinologist, and it is as in our unit, they are seen in the joint obstetric endocrine clinic. It's more important that the endocrinologists are involved in the management of moderate and high risk cases, and such cases should the care of such cases should be shared with the tertiary center. So just a bit about the grading, how we grade these disorders. So the low risk lesions, as has been discussed before, it poses no detectable increased risk of maternal mortality, no to a mild increase in morbidity. And the antenatal care and delivery can be in the local hospital, but there should be a plan for escalation if there is clinical deterioration. And the low risk category includes pituitary microadenomas, hypothyroidism, adrenal insufficiency like Addison's disease, and benign adrenal adenomas or non-functioning tumors. Going to the moderate risk lesions. So this poses a small increased risk of maternal mortality and a moderate increase in morbidity. Such cases are referred to the joint obstetric endocrine clinic with a possibility of shared care with tertiary center. And these lesions, they will include pituitary macroadenomas, which is tumors more than 10 millimeters, diabetes insipidus, hyperthyroidism, hypo and hyperparathyroidism, adrenal disease like Cushing syndrome, Conn syndrome, and of course, congenital adrenal hyperplasia. And the high risk lesions, they pose extreme high risk of maternal mortality and a severe risk in morbidity. Pregnancy is usually contraindicated, and if the patient falls pregnant, the plan is to discuss termination of pregnancy with the patient. If the patient does want to continue pregnancy, then she has to be managed in the tertiary center. Pheochromocytoma is one of the high-risk lesions. So we'll now discuss the moderate and high lesions one by one, starting with diabetes insipidus. It's extremely rare, 1 in 30,000 pregnancies. There are many causes which may either predate pregnancy or they may begin during pregnancy. Most common are polyuria and polydipsia, but again, it can be a bit difficult because this might be common in pregnancy anyways. The symptoms, so the main pathophysiology for the worsening of symptoms is because of the placental vasopressinase, which is produced during pregnancy. And the physiology in pregnancy results in the associated reduction in the antidiuretic hormone levels. So how is this managed? So the mainstream management is desmopressin, and fortunately there are no adverse effects on the fetus, so we can use the ADH analogs during pregnancy. The patients might require higher dose because of the reduced levels of ADH in pregnancy. As we know, there are two types of diabetes insipidus, the central and the nephrogenic. So if it is central, then we can definitely treat it with desmopressin. But if it's nephrogenic, then these patients are found to be resistant to both the ADH analogs and vasopressin. And we should be then focusing more on finding out the underlying causes and addressing them. So it's really important from the obstetrics point of view to remember, because the diabetes insipidus is a disorder of posterior pituitary. We know that the oxytocin is also secreted from the posterior pituitary. So this can have an effect on the oxytocin production, which can be reduced in these patients. So, and this might actually result in slow progress of labor and even uterine atony. So I think if any of us do come across such patients, this is what we need to remember and keep in the back of our minds. Going on to hyperparathyroidism. Again, primary hyperparathyroidism is as rare as 8 in 100,000 women of reproductive age group. From our perspective, the importance is that it can cause hypertension and preeclampsia in up to 25% of patients. Fetal mortality can go up to 40% if the serum calcium is found to be more than 3.5 millimoles per liter. The safe number for serum calcium is found to be 2.85. So if it is less than that, there is little or no mortality associated with it. Obstetrically, this condition can cause an increased risk in miscarriage, intrauterine growth restriction, stillbirth, neonatal tetany, and neonatal death. If we are suspecting this condition, isotope studies are unfortunately contraindicated in pregnancy, but we can start off with ultrasound. Second trimester is, as always, the safest trimester if any surgery is preferable. And surgery is usually the mainstay if we think that the levels of calcium are reaching the magic number of 2.85 in the second trimester. And this is essentially to prevent fetal loss. Coming to hypoparathyroidism, again, it is very rare. but it's most commonly the complication of thyroid surgery. It can be treated with the active form of vitamin D, which is calcitriol. Most of the evidence that we have about its usage is around calcitriol. We can also use alpha calcidol, which is metabolized into the active form of vitamin D, but we don't have any evidence to support its usage in pregnancy. So a bit of pathophysiology. Because we know that pregnancy can actually alter the physiology. There is increased calcium demand during pregnancy and lactation, and the various physiological adaptations include the production of parathyroid hormone. So that is why the management of hypoparathyroidism can be a bit challenging and unpredictable in pregnancy. The usual symptoms can be cramps, tetany, seizures, and congestive heart failure. Obstetric risks are miscarriage, preterm labor, and dysfunctional labor. And the fetal complications can be insufficient mineralization because of calcium deficiency, intrauterine fractures, intracranial bleed, and neonatal hyperparathyroidism, because the fetus is trying to overcompensate for the fetal parathyroids try to overcompensate for the maternal hypoparathyroidism. So the mainstay of management is that we need to make sure that we're using minimal doses to balance against the risk of teratogenicity. The requirements can be variable in the second half of pregnancy, and they may decrease during lactation. So it's really important for us to make sure that we are tweaking the doses accordingly. There are no set guidelines to monitor calcium levels, but usually we tend to monitor the calcium levels every 3 to 4 weeks during pregnancy, once at delivery, 1 week postpartum, and then every 4 to 6 weeks while breastfeeding. Again, these levels are going to guide us to tweak the dose of the calcitriol that we'll give her. And the neonatal levels should be checked during the first few weeks of life, because, as I mentioned before, that it can cause hyperparathyroidism in the neonates. So it's very important for us to be keeping an eye on the babies as well. In moving on to Cushing syndrome, so it's a very rare in pregnancy. Cushing syndrome is when there is excess glucocorticoid production, regardless of the cause. And if we know that the excess glucocorticoid is produced by the pituitary tumor, then we say that it's Cushing's disease. It is said that 50% of the cases are due to adrenal adenomas. So if adrenal adenoma is suspected, we need to liaise urgently with the endocrinologist and refer the patient to a tertiary center. If the patient is a known case of previously treated Cushing syndrome and she has a complete resolution, it fortunately does not alter the course of pregnancy. The main thing to be aware of in Cushing syndrome is that the most clinical features, they do overlap with pregnancy, but the most specific features are the ones that we need to pay attention to. So they are the red and purple stria, and usually in pregnancy, we'll see the pale stria, which are the stretch marks that we can usually see. The patient can present more specifically with proximal myopathy, fractures due to osteopenia or osteoporosis, and they may be features of hyperandrogenism like hirsutism and acne as well. So again, from our point of view, there's a risk of hypertension in 68% of the cases, preeclampsia in 9%, risk of preterm delivery in 43%, and stillbirth in 6%. So the risk of untreated Cushing syndrome is pretty high in pregnancy. Again, the neonates are going to suffer with adrenal insufficiency because the fetal cortisol production is suppressed in utero because of the high cortisol maternal levels. It is said that there is an improved live birth rate in those patients in whom the treatment is commenced before 20 weeks gestation. MRI is warranted if there is even the slightest of suspicion of an adrenal carcinoma. Surgery is always the mainstay of treatment, usually preferred in the first and second trimester, but there have been cases in whom the patients have been successfully operated in the third trimester if absolutely required. Coming to Conn syndrome, it is rarely reported in pregnancy, reflects the underdiagnosis because the incidence in non-pregnant population is comparatively higher, and probably we are underdiagnosing Conn syndrome in pregnancy. We need to remember the triad for Conn syndrome, which is hypertension, hypokalemia, and metabolic alkalosis, which again stresses the importance of urinase and the PET bloods that we usually send off in every case of hypertension. Again, the most common etiology is supposed to be adrenal adenoma in 75% of the patients. Urgent referral to the endocrinologist has to be made if there's any suspicion of Conn syndrome. Primary hyperaldosteronism is when there's an elevated aldosterone level with suppressed renin levels, and the imaging of adrenals should be considered. In this case, if we don't find an adenoma or the biochemistry is unequivocal, we can actually postpone further investigations till after delivery. There are high rates of preeclampsia with corresponding increase in abruption and preterm delivery if there's an underlying Conn syndrome. The mainstay management is controlling the hypertension with antihypertensives and spironolactone. Spironolactone should be used in caution in pregnancy because of its anti-androgen effects. And it can be used safely if we know that the fetus is confirmed female. Another alternative is amiloride, which can be used in pregnancy as well. And there have been cases of laparoscopic adrenalectomy that have been done safely in pregnancy. Coming to congenital adrenal hyperplasia. So this condition mainly is because of the enzymatic defects in the adrenal steroid synthesis. Most commonly 21-hydroxylase deficiency in 90% of the cases. And the remaining cases are because of 11-hydroxylase deficiency. The classical CAH is pretty rare. It is 1 in 14,000 and it is autosomal recessive. So that is why we need to make sure that the couple are actually investigated from the genetic point of view. The salt wasting that we see in CAH is mainly due to the 21-hydroxylase deficiency. The hormonal deficiency is that there's decreased cortisol, decreased aldosterone, and there's increased androgen synthesis. And there's a deficiency of both glucocorticoid and mineralocorticoids. There's obviously a higher risk of miscarriage, PIH, GDM, IUGR, and mainly electrolyte imbalances. Adequate glucocorticoid and mineralocorticoid should be replaced. There should be an increased steroids covered during labor and delivery, increased surveillance for preeclampsia. The delivery can be complicated due to cephalopelvic disproportion in these patients, which can be secondary to the android pelvis, or previous genital surgery can make a vaginal delivery difficult as well. If the fetus is at risk, the couple is referred for preconceptional genetic counseling. If one of them is already affected, or we have an affected child or partner of an affected woman is a carrier, termination of pregnancy is recommended if the female fetus is affected, or we can offer them high-dose dexamethasone, 1 to 1.5 milligrams per day to suppress fetal adrenal production and prevent masculinization of female fetus. Treatment is preferably started at preconception or at least before 5 weeks of gestation. Chorionic villi sampling for genetic diagnosis at 9 to 1 weeks is recommended only if we know that there is a previously affected child, or if we need to know each of the parents' genetic mutation. So a little bit of math. So we know that it is an autosomal recessive. So there's 1 in 4 chance of the fetus being affected. And again, because this affects the female fetus, 1 in 2 chance of the fetus being female. So overall, there's only a 1 in 8 chance that the fetus will benefit from high-dose steroid. And 7 out of 8 fetuses are going to be receiving high-dose steroids till 6 weeks at least. So the mainstay management is close liaison with a neonatology team. The female neonates should receive corticosteroids even after they are born to treat the condition and also to counteract the neonatal adrenal suppression secondary to the long-term dexamethasone that the mother receives. If the female fetus is affected, the treatment of the mother should be continued till term. Male fetuses do not require treatment in utero. And again, the parents should be carefully and fully counsel that prevention of the virilization of female fetus is not always possible, even if we start the treatment early. So this is an interesting case of CAH that we encountered. So she was a 34-year-old known case. Her father was negative for any mutations. The patient herself was diagnosed when she was 2 years old and had a clitoral reduction surgery. Fetal medicine counseling was offered, and it was known that there was no added risk to the baby. She was followed regularly in the joint antenatal endocrine clinic. She was already on prednisolone 6 milligrams and fludrocortisone 100 milligrams daily. The plan was to offer her GDM screening as well, and she was having Usenis done on a six weekly basis. The testosterone levels also were being checked every 6 weeks. She had a very uneventful pregnancy. The plan was to avoid prolonged labor, to make sure that we are monitoring her Usenis in labor with a strict input-output of urine. She was also given the stress dose for steroids. The patient was suitable for normal vaginal delivery because she's had a previous genital surgery as a child. She was examined antenatally and was found suitable for normal vaginal delivery. The patient ruptured her membrane spontaneously at term +3. She had a prolonged first stage of labor. We augmented her with syntocinon. She had a prolonged second stage, was then delivered with forceps. The patient developed the decreased urine output, and the Usenis reflected dilutional hyponatremia. So two things to remember here is that we know that this patient was prone to deranged Usenis, and plus she received prolonged oxytocin, which in itself can cause hyponatremia in patients. Of course, the patient found this experience pretty traumatic. The baby, fortunately, did not was all right, did not require any neonatal admission. She's now currently pregnant the second time. She is, and so what do you guys think? Will it be all right for us to offer her a normal vaginal delivery, or?
We need to know your thoughts, because I need to discuss with her. She's coming to see me very soon. She's 28 weeks, and we need to decide by 32 weeks. What do you think? What do you all think?
What in particular did she find traumatic?
I think, as you can see, having prolonged labor with primaries, especially if they're rupture membranes, is not that difficult. But she had a prolonged stay in hospital. All her Usenis were deranged. And I would say partly we were responsible for it as well, because the plan was not to avoid prolonged labor. And this lady was allowed to labor as, when you have a busy labor ward and being given like 4 hours in second stage and things like that. They both are doctors themselves, very well educated. Now she's under UCLH, and the endocrine team from UCLH has now wrote to me saying patient has found the whole experience very traumatic. And what are your thoughts about it? What can we do?
So I think, from my perspective, if the patient wants to go ahead with the section, she should happily be offered one.
Okay, that's good. What about others? The reason why I'm asking you this question is I know we have busy labor wards. She had a forceps anyway. We could have curtailed her second stage by forceps. Also, there was delay at every stage. Epidural was delayed. Syntocinon infusion was delayed. Busyness of the labor ward affects, but patients like this lady, she was on the labor ward because she was considered high risk, and unfortunately we failed to provide her the care. And even if there was a plan made in her notes, it wasn't followed. So just so that, I mean, I know it's probably something you can't interfere with, or you can't affect the decisions, but it's something when you become registrars, it is something to bear in mind. The registrar took other patient to theatre for section when this patient should have been delivered earlier than considering. I mean, at the end of the day, when you are on a labor ward, you need to decide and prioritize your work. So this patient should have been prioritized when there was a clear mention that she should not be allowed to labor for a long time, because the problem is she was given it's just this, she's on oxytocin, which added to the dilutional, which added to the hyponatremia.
Yeah.
Okay, so I mean, it's very difficult situation. I'm going to have a open discussion with her when I see her, that the thing is, I can put a plan in the notes, but unfortunately it didn't follow last time, so she has lost faith. So it's a difficult time, but let's see what she comes up with, because otherwise, once she settled on it, very straightforward pregnancy. Bear in mind, congenital adrenal hyperplasia is not common in itself. And having a problem, but having a very straightforward pregnancy, but then the labor, which was partly complicated because at times the decision making wasn't up to the mark. That's why I wanted to discuss this case. Okay.
All right, so moving on to the last lesion now. It's the high-risk lesion, the only one, pheochromocytoma. It's fortunately very uncommon in pregnancy, but if undiagnosed, it can have a mortality rate of up to 50%, especially at the time of labor or during induction of general anesthetic. The fetal mortality also is 26% in undiagnosed and 11% in diagnosed cases. In pregnancy, the high risk of hypertensive crisis or congestive heart failure. And the main pathophysiology is that the catecholamines which are produced can result in uteroplacental vasoconstriction and placental insufficiency, or they can also result in abruption. So what we should be looking for, again, we should be looking for paroxysmal hypertension, orthostasis, very high blood pressure, but absence of proteinuria and edema. And if the patient is complaining of palpitations and headaches, that should be some red flag signs that we should be aware of. Diagnosis is the measurement of catecholamines and their metabolites on the fasted blood sample or in the 24-hour urine collection. Elevated metanephrine excretion is the most sensitive test. MRI is the investigation of choice if there's any suspicion. And once suspected, they should be immediately referred to a tertiary care center, and termination of pregnancy should be offered. If the pregnancy continues, pharmacological blockade and surgery are again the mainstay treatment. Cesarean delivery is recommended in these cases, and it's preferred to minimize catecholamine surge during labor. So this is the intrapartum care plan for all endocrine disorders. If we have any patients with endocrinopathies, there should always be a senior input, a multidisciplinary care plan, and a clear management plan should be put in place for every patient. We can aim for vaginal deliveries, except for cases in cases of pheochromocytoma. The antenatal review by obstetric anesthetist if the patient is on long-term steroids, because the patient will need stress dose steroids at the onset of labor, or if they need a C-section, and that will be repeated every 6 to 8 hours till the patient can take them orally again. Syntocinon is preferred over symptometrin if there is a possibility of hypertensive surges in patients. Postnatal care plan is usually individualized depending upon the severity and the nature of the endocrine disorder in the patient. Before the patient is discharged, we should make sure that there's an appropriate follow-up arranged for the patient, and the medication should be reviewed before the patient is discharged, because as I mentioned before, there could be some tweaks required in the medications in the postpartum period. And again, we should make sure that we discharge the patient with a comprehensive discharge summary. And it should include all the information that will help if the patient comes back as pregnant again. And that's it from my side.
Thank you, Meeta. I'm just wondering if you stop sharing.
Yes, is it all right if I go to theater because the patient is ready?
Yeah. You please. Thank you very much, Meeta. I will carry on. If there are any questions you want to ask, please feel free. This is your time. And I was just wondering if you have not got the QR code for doing the feedback, because I think for Zoe and Meeta it's going to be quite useful, of course, for me as well. To if you haven't got it, if you just copy this now, please, and then we can do the discussion.
Mayura, very quickly, Despina had her hand up.
Yeah, please go ahead.
I have a question with regards to hyperparathyroidism and if they are in fact hypercalcemic, and it was mentioned that they're at higher risk of PET. Are there any changes that we need to be making or any monitoring if they need magnesium sulfate if they are hypercalcemic?
I am not aware that there would be any changes required, but I think this is personally, as I said, that I haven't come across this situation. And what is making you think that there would be a need for change? What makes you think about it?
Isn't calcium gluconate the antagonist if they have magnesium toxicity from magnesium sulfate? So would that extra calcium from the hypercalcemia antagonize magnesium sulfate? So would they need adjustment in the dosage or the duration?
Okay. Oh, okay. Yeah, you're thinking in that way. I mean, personally, I must admit that I may not have an answer to this question. I'm more than happy to check with the endocrine team because I have not thought about it. As I said, that hyperparathyroidism, it's in itself, it's such an uncommon thing. I have seen only one patient in last so many years. But I can ask you, I can ask them and feed it back to you. But yes, you are right, because if they are at risk of preeclampsia and if we are giving max self, I mean, personally, I don't think it should cause a problem because I have never had to give antidote at any time. But because if they have a high calcium, it makes sense. But I genuinely don't know the answers, I have to admit.
Thank you.
No problem. Is there anything anybody wants to ask, and anything which you have learned new you want to share? The plan was for the endocrine team to be around for answering the difficult questions, especially if we don't know, because we would always get a kind of input from them if we are not sure of things, especially management plan, intrapartum care plan. So as I mentioned to you that these are some of the endocrine disorders, especially the moderate and high risk ones, are very rare. From pheochromocytoma perspective, I remember I have literally just seen the only one case of in so many years of doing obstetrics. And that was when I was a SHO. I was very scared. I didn't know what to do. 12 weeks pregnant patient came in with blood pressure of 180, 110. GP phoned me saying this is what, and I thought, okay, it's very early on to get preeclampsia, but I don't know. This was my first year, and admitted, started doing preeclampsia screen, called my boss because I was so worried. I didn't know how to manage this. Eventually, she didn't know either, obviously, because there was not much of a proteinuria, but typically patient had severe headaches as well. So we thought, what else can it be? Maybe even if it's not a proteinuria, it's probably just a hypertension and headache. Just has to be preeclampsia. We started giving her medication. She almost needed triple therapy. to manage her blood pressure. It was so high at one point of time. And then suddenly I got a call next day to say that her blood pressure was going on the low side. As you understand that there can be paroxysmal hypertension episode. So it was very difficult, even tricky to know that it could be something like a pheochromocytoma. Then we involved medics. Then she had several tests, and eventually pheochromocytoma was diagnosed. In the meantime, we were just managing her as you would manage any other preeclamptic, assuming she is preeclamptic. The other discussion was, do we need to terminate the pregnancy because her blood pressure is so labile? How do we manage it? But eventually we managed to get a control over situation. We had MDT input, and this lady then had a laparoscopic surgery and around 16 weeks time, and eventually had a very straightforward pregnancy after the surgery. So these are very rare patients. We don't see them very often, and that's why it's important to know, like as we were discussing about the pituitary tumors as well, they don't necessarily grow in pregnancy. They hardly grow, and to cause a problem to the extent where somebody needs a surgery is extremely rare. Even the MDT was struggling what to do, how to manage these kind of cases. But there is always a little take-home message, and that's why I wanted to present. You may not ever see these patients. I may not ever see somebody who needs surgery while they are pregnant, but again, something we all need to learn and have at the back of our mind that this can happen. And so just starting from like thyroid, because I know you had a lot going through lots of things, but within my remit, if there are any questions, feel free to ask anything about thyroid that you don't understand. And the take-home message is TSH of less than 2.5, yeah, in pregnancy. Just make sure that the TSH is less than 2.5. I mean, you can switch on your video and ask question if you want to ask any.